Hi, this is Steele, and I've got Michael Braccio with me. And we did an awesome webinar. This was probably a couple months ago on the shoulder, and I learned a couple cool things from Dr. Braccio, and I've incorporated them in my practice. I've never read these things before, never heard them before, and now I have someone younger, smarter, and with more hair than I who is teaching me how to treat the shoulder, and I loved it so much. I thought about the rotator cuff, and I thought about what's the next rotator cuff, and the rotator cuff of the hip is the butt muscles and the things going on around the hip. So I thought to myself, what else can I learn from Dr. Braccio? And most importantly, what can we all learn from Dr. Braccio? So thanks for being on board.
Thanks for having me back. Very, very kind words there. I think the only thing that you said that was true there is that I'm younger. I think that's about it.
Yeah, I try to convince people I'm still 25, but it doesn't go very well when you have a 12-year-old. But, I think that, a lot of times we hear about things in school and we get those diagnoses. And what I've learned is consummate with your education is how well you diagnose, meaning I've got a 4-year-old also that can tell me he has hip pain. I have a 12-year-old who can tell me he sprained something or he pulled a muscle. I have, people that I see in college who come in, or high school kids, and they can tell you what a fracture is. They can tell you what, a tendonitis is. And then, my first trimester students are people coming in from Logan or National can sometimes tell me what osteoarthritis is or bursitis is. But the hip is goofy. The hip's kind of like the shoulder. And I think that the more we understand about the hip and all the different complexities around the hip, really, the better off we're able to treat patients. First off, understanding if the problem is within the joint, and then understanding if there's problems outside of the joint, and very different treatment strategies based on the tissues that are injured and how it happened. So I'm going to put you on the spot just a little bit. I gave you a little bit of questions at the very beginning, but we're going to pick your brain to see how fast you think. And
of course.
So first off, I want everybody to understand, what is your demographic of patients that you see?
Yep. So majority of my clinical career, I've been in Seattle. And so we're kind of a very tech driven place, a lot of Amazon, a lot of Microsoft, and some Google employees. And so I generally see people between probably 25 to 40 is probably the majority of my clientele. And a lot of them, they are active in some capacity, whether they're joining a recreational kickball league, dodgeball, ultimate frisbee is really big up here, soccer, that kind of stuff. But, I also see a lot of people who go to the gym, whether it's CrossFit, they have their own plans that they're kind of just going to the gym and doing, maybe working with a trainer. So I would say, my demographic is a little bit atypical in just that, it's a younger demographic and they're quite active. And so you really never know what you're going to see when they come in, because they can call you up and be like, hey, I was running and I felt something pop, I twisted this way. And they're like, I think I fractured something or, tore something. So you never really know what they're exactly going to come in with when they schedule an appointment for Monday mornings.
So you've got a demographic that is almost everybody's dream demographic. In my area, I'm in St. Louis, and we see everybody, but we see mostly an older population, a painful population, and a sedentary population. So my number one and my number two diagnoses that I see for hip are probably much different than yours, just because of the continuum of the hip problems we can have. So what are your number one and number two diagnoses that you're going to see? And we're going to talk about the hip, but we're talking about the pelvic region, below the back and above the knee. So what are your number one and number two?
Yep. Well, it's very interesting because like my number one and number two, they weren't necessarily talked a lot in school, right? I kind of had to learn a lot of this on the fly because one of them is proximal hamstring tendinopathy. Mm-hmm. And the other one is adductor-related groin pain, like a sports hernia, an adductor tendon issue, whatever you kind of want to call it. Those have somehow become my number one and number two hip-related diagnoses. And it's weird because I never sought out to really be the person on either one of those, but one person would come in and be like, hey, I've got this weird, hamstring pain. It's been nagging me for several years. Then you start treating, working with them, and then they have a friend who has the same thing. And then all of a sudden your demographic looks nothing like you would have expected it, because everybody's coming in with, a hamstring issue. And you got to remember if it's this person, has a left-sided one or a right-sided one, because they all look the same.
Yeah, and I think that's one of the biggest things that we all learn in practice is that once you get, I don't want to say good at something, but once you become very efficient at doing one diagnosis. For myself, I worked with an oral surgeon when I first got out, and I just did his myofascial work for TMJ issues and TMD disorders. And by no means was I an expert in TMD. That's just what I did, and I got a reputation with oral surgeons and dentists that I was some guru. And I had taken a couple of classes, and I turned into somebody who was maybe a little more competent. But if you do a good job, the benefit of that is you have people come see you. Let's look at hamstring issues. If you had to say, what are the number one signs and symptoms of a proximal hamstring tendonitis, tendinopathy, tendinosis, that kind of model? What are the signs and symptoms?
Yep. Generally, they're coming in with like ischial tuberosity pain, somewhere right at the bottom. If we're looking at just from an anatomical perspective, it's not right in the glute, right? If we're looking at somebody with like maybe a referral from a facet or maybe just like a glute related issue, the pain seems to be much lower than that, right at the attachment of where the hamstring attaches onto that ischial tuberosity. And generally they're going to complain of pain with sitting. That seems to be one of the most common complaints that can kind of like start tipping you towards that proximal hamstring diagnosis.
So just to interrupt you, what pain with sitting, and we get a lot of people with neural tension signs with sitting, where they start to feel pain, numbness, or tingling, any kind of paresthesia symptoms. How would you differentiate something like a Meng syndrome, something like a sciatica from a proximal hamstring issue?
Yep. The neurodynamic tests are phenomenal for this. So if we're looking at, because like a proximal hamstring issue is going to be more compression, right? You have the ischial tuberosity sitting here, and then you have that hamstring, and it's just that compression against it which is causing the irritation. If we are looking at something from a referral from the low back, whether it's sciatica, disc herniation, Meng, something like that, if we start to do a slump, so if we just have them sit and they go, okay, if we're in that slump position, does that increase your pain either right in the glutes, right in the ischial tuberosity? And they go, yeah, that increases it quite a bit. Then we're looking much more towards a low back origin versus proximal hamstring tendon issue, because if we slump, you're not really changing the compressive factors by just kind of moving that low back.
That's great. That's something really to not do more tests, but essentially what you're doing is exploiting the test. By understanding the chief dysfunction as far as compression and limiting for that variable, you can modify tests around that. Since you have that fixed, well, I guess it is fixed since you're sitting on it, that fixed variable. And I love that, because so many times people say, this exercise or this orthopedic test doesn't identify or fix this problem, and it's not. It's a constellation of symptoms that help us to develop a diagnosis and help treat it. So talking about treating, what are your go-tos? If I had let's call it a little more chronic. Let's say it's not acute. So this is a pain only when sitting on it, maybe when they're trying to run a little faster. What are your go-to treatments for a proximal hamstring issue?
Yep. It depends on how they're presenting, right? Because whenever we treat people, it always depends on the actual person, right? If they're a young, active go-getter, then you might push them a little bit harder. If it's somebody who is a little bit more tentative, you might scale back the rehab and kind of just gradually progress them a little bit slower. But basically the reason why I say that is because I'll either start off with an isometric hold for the hamstring. So basically we take a glute bridge, move our feet out further away from us so that we're actually stressing the hamstring more than we are the glute. And so I would start with an isometric for that tentative person or somebody who's just has a lot of just like fear of movement, right? They're just scared to load that hamstring. It hurts too bad. They're fearful of like anything kind of just flaring it up. So for that person, I might start them off with an isometric hold just to kind of get them used to loading that hamstring. But if I can, I'll start people on like a concentric, eccentric, long lever bridge, which is that same isometric exercise, and just start them really loading up that hamstring to start building some capacity on that proximal hamstring.
And what kind of tempo to use as far as going up versus down? Does it matter?
Maybe. I typically use a 3 or 4 second tempo for concentric and then eccentric. So the total duration is about 6 to 8 seconds for the full exercise. It's interesting when we kind of look at how we change these exercises, right? Like, is it better to have a longer tempo, so longer duration under load, or should we load heavier, right? Which one's going to produce a better outcome? I don't know. But
well, that was my next question. So,
but
then what how are you going to progress them? What's the not the final exercise, but what's the next one?
Yeah. Well, I guess to go back into that, since I kind of answered your question before you asked it, is that I would start off with a slower tempo, right? That 3 to 4 second contraction, because I want them to be able to control and be able to contract the hamstring in a variety of different positions and not just kind of power through that movement, right? Where they're just kind of like up, down, up, down, up, down. And you're just skipping over majority of the range of motion because you can't control it. So I'd rather them own the movement than the movement own them.
Okay.
And then I progress load to make the exercise harder overall.
Okay. How would you load up the hamstring a little bit more? What would be an example of that?
Yep. Are you familiar with like the hip thrust exercise for the glutes?
Sure.
Yeah. Basically, I take a modification of that. So put the feet on like a bench, chair, something like that, and then put some sort of load on like right on top of their pelvis. Whether that's a barbell, a lot of people are working from home right now, so a backpack works great with a couple of books in it. Maybe a gallon of milk or something like that, something to just kind of add some external load. Okay.
Or your kids or your dog or whatever's around.
Yeah. Get a little bit of perturbation in there with the dog, trying to get him to stay.
So how long would it take? And I know there's a lot of variety in here, but if someone comes in with an acute hamstring issue, a lot of these things turn chronic. And I think the chronicity is somewhat due to maybe a failure of their correct diagnosis from the beginning. But let's say you get them on the right diagnosis. It's only been going on for a little bit, maybe a week, maybe 2 weeks. How long would it take to get that to calm down, assuming this is an acute problem, not chronic at all, never had the problem before?
Yeah. I think typically acute issues, there's a lot more receptiveness of the body to kind of change, right? And so we can take somebody and we'll say 2 to 4 weeks, it should start to calm down, depending on, obviously like the intensity and compliance and all that kind of stuff is going to be a factor. But in that 2 to 4 week time span, we should kind of know like, okay, do we have the diagnosis right? Are we on the right path with treatment, or do we need to change it, or is it a different diagnosis? Do we need imaging? Is it something different? But typically in that 2 to 4 week time span, I generally see some sort of indication that we're getting it to calm down.
And the appropriate imaging for that would be X-rays and thermography, right?
100%. 100%.
So what would you use?
You would either use an MRI or a diagnostic ultrasound. They typically both will give you some good information. It just depends on what's available. Ultrasound's a little bit harder because it has a lot to do with the technician that's doing it versus an MRI. You're basically in a machine, so you're probably going to see much more.
I have a very big interest in the next one. You talked about adductor issues, and my kids all play soccer, so we see a lot of these, and definitely in the non-skeleton mature population playing an athletic activity and a triplanar activity where they're cutting back and forth and making different kinds of maneuvers and kicking, which we'll see these things happen. So this was your number two as far as the cause. What do you do for these people? What are the management tools that we can use for? I'm sorry, let's go back. The signs and symptoms of somebody with an adductor strain.
Yep. I think for these people, one of the biggest tells is what they do, like in their history, because a lot of these, like you mentioned, they're not necessarily going to be runners where they're just going in one plane. Most adductor issues, there's going to be a lot of shifting. So looking at soccer, there's a lot of stop, start, cut, quick acceleration, quick deceleration type of movements. And so that's why, like, a lot of my ultimate Frisbee players, they present with this because they're running as fast as they can. They stop, catch the disc, change directions, pivot, throw, sprint again. I'm a hockey player, so, thankfully I haven't had it, but just because there's a lot of that striding out with that leg, you're putting a ton of pressure on that adductor, not only from when you're pushing out, because that adductor has to work eccentrically to slow down at the end, but then you're stressing or stretching it as much as you can, and then asking it to bring that leg back. So I feel like generally with history, it tells you a lot whether you're going to actually expect something like this, just because, you got to stress the adductor, and it's not a muscle you would typically stress that much, with kind of like daily activities.
Let me just go off on a little small tangent, because whenever someone comes in to see me, I always tell them, listen, this is something that you created. This is assuming it's not a trauma, something that was a one-off injury. I always tell people that you have to eliminate all variables, which is usually their mechanical sensitivity, the way they sit, the way they play hockey, whatever it is. Are you in the same camp, or do you still, even if you're treating that, do you still let them play hockey in that kind of case, or do you back them off all activity?
For adductor specifically, I'm a little bit more firm on limiting their activity. I think both proximal hamstring tendinopathy and adductor related groin pain, they can be pretty difficult to treat just because they seem not to be very responsive. You have an ankle sprain, we kind of know the general steps, we know the general time frame, you're kind of on your way. With these, they seem to be very slow to respond, mostly because they're usually a little bit more chronic than they are acute. And so specifically with adductor groin pain, I'm a little bit more firm of being like, you know what, this is something we actually need to rest, modify whatever it is. If we're playing hockey, if we're playing soccer, we need to kind of put a little bit of distance in between you and that activity for right now, while we actually get it to calm down and then build up the strength again.
And I'm assuming, just based off what you said last time, building that strength, are you going to go in the same pattern? Is it still going to be isometric, concentric, eccentric, and then some plyometric or dynamic loading?
Yep. You kind of picked up on my pattern here. For the adductor, I do a little bit different type of work, just because it seems that when you move that hip into flexion and extension and then test the adductors, there's different responses. Some people will have pain with the hip at maybe, we'll say 90 degrees versus at 0 degrees. And so we have a little bit more range of motion to kind of play with these when we're looking at starting to kind of load it. So if they're very irritated, typically closer to just 0 hip flexion, or I guess just in neutral, that's typically the area where most people experience pain. And so we can load them into a little bit more hip flexion and then stress that adductor and then slowly work our way back.
Okay. No, that makes sense. And I think that one thing that, if you look at the shoulder, so empty can test. So the way you learn it is you learn it in scapular plane and 90 degrees. And while that's true, that's the most common area you're going to find that impingement or reproduction of pain. Often I find it down at 20 degrees. I find it somewhere at 45 degrees. I find it in different regions. So do you find that often that when you're testing different muscles in this kind of a case, that it is different segments of motion? They're going to stress that muscle more, and that's where you're going to get that tensile strength across that injured tissue and reproduce their pain?
Yeah. For example, like when I first started treating like proximal hamstring tendon issues, like there's not a lot of great orthopedic tests specifically for it, right? And I mean, like we could probably extrapolate to orthopedic testing in general. Like it gives you some indication, but like there's usually not one test and you're like, that's it.
So we're going to stop right here. So I'm a diploma in orthopedics.
I know.
That was a little bit of it. No, I agree with you 100%. Yeah. Carry on.
Right. I was like, I'm treading into some deep water here.
No.
But when we're testing things, we want to test in a variety of different positions, right? Like it's not good enough just to, like you're saying, like for empty can, just to test always at 90 degrees, scaption, all that kind of stuff. Well, what if they actually have pain up higher? Why can't I test them up here? If they have pain lower, why can't I test them down here? And so like for the proximal hamstring, instead of just doing the hamstring test at, patient supine, hip at like 45 degrees, and then you kind of lift up the leg and then have them push down into your hand. I'll bring them into a little bit more hip extension and then have them repeat the test there, because that's typically when they're having the pain. Or I'll bring them all the way into hip flexion, so I'm really compressing that tendon against the ischial tuberosity, and then asking them to contract the hamstring in that position. Same thing with adductor, right? There's a bunch of different adductor muscles there. They kind of all insert on the pelvis. So we want to see, well, like, which one is it more likely that's actually causing the pain? And so as we kind of go up into flexion, we might get more pectineus. And then, as we kind of go down, more longus, magnus, and then down into gracilis, right? As we kind of just like work down. It's not perfect by any means, but it kind of just helps us go, okay, we're testing in a couple of different areas. Now we kind of know like what are the hot spots, and then what are the areas we can kind of exploit when we're looking at like, where can I start loading? Well, if you're okay at loading at 90 degrees of hip flexion, we're going to start there. Oh, you're not good there? We'll start in more hip extension. Whatever it may be, it gives you a place to kind of start that rehab process.
Sure. And for anybody who is already a subscriber of ChiroUp, all of our thigh squeeze test. So if you go in the orthopedic section, you can search for thigh squeeze, adductor squeeze. And if you look at all the lag signs, LAG signs for the shoulder, for the hip, there's a lot of good ones that will really kind of find those arcs of motion that cause pain. And the more you understand the tests and understand how useless they are in isolation, the more creative you get. And I don't think orthopedic testing is useless. I don't think rehab is useless. I don't think a lot of stuff we do is useless, but I think it is all useless in isolation. It's like me saying that I'm going to manipulate your back and all your pain's going to go away. Well, that's not true. Right. Can it make it better in the long run? Can I identify something in the short run? Can I do an exercise that makes you feel better in the short term? Probably, for most anything. But the real gold comes into that creativity in coming up with the best diagnosis and the best recipe for treatment and the best ways to educate our patients. And when you can mold all those things in together and make it efficient for you as a provider to do on a regular basis, that's the cool part. And I think we talked before this. One thing that Dr. Braccio taught me was having your patients squeeze something tighter when they have a shoulder problem. I was like, what is this guy talking about? I'm not going to have my patients squeeze a weight harder when they're doing, eccentric loading for their shoulder exercises. And I'll be damned. Yeah, I started doing that with my patients, and it helped. And not only did it help them, but it also helped them their ADLs when they're getting the milk out of the refrigerator. They started to grip the gallon of milk a little bit harder. And just those little pieces, those little nuggets that help us so much. I have patients who will get this kind of a problem, get this groin pain. And what I've seen most common is a groin pain when it's really deep. A lot of times that could be intra-articular, something like an impingement syndrome in your population, something probably like an osteoarthritis in my population, just based off the activity levels.
Sure.
let's differentiate this. So how would I say this is an impingement syndrome, or this is let's say, a pincer or a cam deformity, or it's an adductor? How would you make that differentiation?
Whew. I honestly, like, I feel like this is tough, right? Because we know that the femoral acetabular impingement syndromes, they can kind of refer pain typically on the front, maybe deep portion of the hips, might radiate a little bit into the groin. Especially, like, one of the other diagnoses we should look at is a labral issue, right? They're going to have radiation down into the groin. They might have popping, snapping, clicking, which kind of, with an adductor related groin pain, you typically don't have those. So that kind of is one of the cues that you could be like, well, maybe this is actually a labral issue. But I feel like in terms of continuums, like, it's very hard to differentiate when it's a muscle or a tendon issue and when it's maybe a labral issue or a structural, a cam or a pincer deformity. You can do the impingement sign with the hip, bringing that hip into flexion, adduction, and internal rotation and seeing if you can stress test it. But, when I've done it on a lot of people, most people are going to say that they're going to have a pinch, and so when do you say, like, well, this is a really bad pinch, and this is kind of like, well, maybe, we are stressing the front aspect of the hip. So, like, yeah, I could see a pinch kind of being a normal thing. And so, like, I would say, like, if you really suspect one of these issues, whether it's a cam or a pincer deformity or a labral issue, you have to have imaging. Whether it's an X-ray for the femoral acetabular type of stuff or an MRI for the labrum, I think that's the only way that you're really going to know if you have one of those other issues.
Now, would you jump into that imaging, or would you jump into a trial of care first?
Depends on the patient. I've always struggled with this because some patients are very adamant about having imaging. They want to know exactly what is going on. And so sometimes you spend so much time telling them, like, I don't think at this point we need it. You haven't tried conservative care. Like, do you really want to spend $1,000 out of pocket for an MRI? And so most of the time I try to steer them and say, like, look, if you haven't tried anything before, or, maybe there was some stuff missing in your treatments before, let's go 4 to 6 weeks, see if we can start to make a change. If we can, whatever structural thing is in there, it might not be that relevant, because we know, like, from looking at a lot of other studies on other areas, some of these structural issues, they don't correlate well, right? We look at, like, we look at MRIs of the shoulders, especially, I forget who did the study, but there was the one on the Major League Baseball pitchers. And, you look at their MRIs and they got full thickness tears, they got labral tears, they got, everything you can imagine. They're out there pitching 100 miles an hour and are asymptomatic. And so even if we do get imaging on these people, like, the question I always ask people when we're kind of deciding if we're going to get imaging is, if we have the imaging, are you going to get surgery? Because that's, if we see a labral issue, we're going to say, well, is this surgical now? If the answer is you're not going to have surgery, then that's when I kind of have that conversation of being like, let's go conservative for a while, because it's not really going to change our care that much. We're still going to try to strengthen the muscles. We're still going to do some soft tissue work. And we're probably going to look at some joint issues to be like, is there some low back issues that are contributing to this? Is it, if we adjust that hip, does that help? All those kind of things. So, do I jump into imaging right away? Typically not.
So I'm glad you brought up the adjust part of it, the manipulation part of it, because I do a lot of talks around here and there for different organizations. And people always, ask me when I'm going to get to the manipulation. That's what we love to hear, pops and cracks. And whenever I go to a certain meeting, somebody performing manipulation is like a bug light. Everybody's got, well, what's going on over there? What do you do? What are as far as this goes, are you still just assessing for restricted joints and adjusting those? Are there certain trends or characteristics that each one of these diagnoses have that you perform something different, a different mobilization, different manipulation to the knee, to the SI joint, to lower back?
Yep. Generally, the answer is no. I don't have like specific adjustments for proximal hamstring tendinopathy, adductor rheumatoid groin pain, whatever it is. I think the big thing when I'm looking at adjusting is I'm looking at what did my physical exam show me.
Sure.
Right? Like if we're having some contributions from the low back, let's say, it makes sense to me to adjust, right? Or if I'm like, well, your L-spine flexion is restricted. Do we want to work on that? Sure. Rotation, is there an asymmetry? Something like that. I think that's really what leads me to adjust, which I think is how everyone should kind of approach it, is be like, don't just do things to do things, right? Just because you're a chiropractor doesn't mean that everybody needs to have an adjustment. I'm a rehab-based guy. Yeah, I know. Sorry, I know. But, same thing with like rehab. Does everybody need a 10-week corrective exercise program for core strengthening? No, I don't think so. I think that's when we really need to put on our clinician hat and be like, what things that I have in my toolbox that will help you the most, right? I think that's what we should be aiming for, because that's our specialty, right? We're supposed to be good at musculoskeletal things, because we always have the same conversation with like the medical profession, right? Like if every time you went to the orthopedic surgeon and they went, that's a surgical case, you'd be like, well, they just sprained their ankle. They don't need to have surgery on the ankle. They're like, no. Like, I'm a surgeon. This person needs surgery. We would have that same conversation with them. So I think we should be held to that same level of being like, let's assess and then treat accordingly, and not just throw the kitchen sink at every single person that comes in.
Yeah, I think that's well put. And I think that right now we're in a period of people looking at telehealth, which I think is a great way to communicate with patients and to make sure that our patients are still successful, even when not coming to see us. And we've been approached by several people to start giving exercises. We'll give them exercise, give them something to do, and or talk to them on the phone. I'm like, that's not what we should be doing. We should be looking at what they're doing in their their home, or in their cutting grass, or getting the milk out of the refrigerator. And rehab becomes just showing the patient what they can be doing, what they should be doing, or how to perform that thing they need to be doing at their own house while they're sleeping on a pillow or going up and down their steps. And so often people get into a recipe mentality, and to a lot of our subscribers, that's what we do. But we create those recipes so we can automate 99% of what you have to do in your office, so you can focus on that 1% that Dr. Braccio was talking about. Focus on that one thing, that one arc of motion, that one isometric exercise that can help get that person out of pain, that you are only given so much time to work with the patient. And if I can have, instead of having 15 minutes with the patient, if I'm taking, 14 minutes of that up, just doing the treatments and the things that I do to everybody, and I forget about that 1%, where I could be taking all 15 minutes of that and focusing on that 1% and forgetting about the things that don't matter that I just do, that's when the clinical gold comes out. And then you start to have people like yourself who become the groin doctor, the butt doctor for the hamstring issues. Hopefully that nickname doesn't stick. But yeah, so
well, now that you said it on your platform, thanks.
Yeah. So do you have any questions? Oh, I just looked on there. My name's Tim Bertelsmann on the interview. I guess I signed in his Zoom account and not my Zoom account. Do you have any questions for me? Anything that I can answer for you?
Let me think here. I know I had a good one about barbecue on our last session.
Yes, you did.
Let's see here. I guess from what are your top two hip diagnoses that you typically see in your population? Because obviously we discussed that, our populations might not be the same, but what are your top two?
My top two are hip pain and muscle tears. No, I'm kidding.
I was gonna say thanks for being so general. Like, yeah, I get a lot of hip pain.
Yeah, we work with a pain management group. So anybody they don't get out of pain, so if they can't inject it and get it out of pain, then they send it to us. And so we do see a lot of patients that have gone through that. And a lot of times I'll get patients who get an injection into their joint, and it doesn't take their pain away. And while the doctor and the patient may see that as a failure, I look at that as an opportunity because I know when I put a pain relieving anti-inflammatory steroid into that hip capsule, it doesn't take their pain away. That doesn't mean they don't have a hip pain. That just means that it's probably not on the inside of the joint. So I'd say the most common thing that we see is more of a glute tendinopathy. So it's going to be in a different location than yours. Yours are more in the groin and in the butt area. Whereas if it's right there on the lateral hip, and right there at the greater trochanter, sometimes even going down a little bit, maybe into the first quarter of the femur, and that localized pain they're going to see there from an insertion point into the femur. I see a lot of those, and those are more my chronic patients. They've had it for a long period of time. It's out there on the outside part of the hip, but they keep on injecting all the different areas, and I think the injections actually hurt that. Instead of suppressing the inflammation, we need to rough it up a little bit. I don't do I love instrument system manipulation and factor and Graston, so I'm not saying anything bad about that. It's just in a sensitive area, so I don't do a lot of that for just that purpose. So I just kind of dig into their butt with my finger, that old trick, and then do a lot of isometrics. So we'll do a lot of just standing on the single leg stance is a good
Oh, nice.
isometric. Even doing side bridges. You may not think of that as a hip exercise, but it really is. And then I'll get into some lunges. And I find when I do like a posterior lunge where they're holding onto something and lunging backward, you can find exactly what you talked about is you can find that arc. You can find that point where they start to feel a tug on that specific tissue, that specific muscle. And so I say, okay, let's hold it right there for about 10 to 20 seconds and then come up, take a rest, walk around the house, and then we'll do it again. So I love isometrics. They aren't as sexy as some of the other exercises.
No,
They're not as
no.
they're not as cool, as far as other things, but they do take away pain. There's some great research for patella tendinopathy with isometrics, but yeah, that's probably my number one. And the only reason is because I do see a lot of acute cases, but when it comes to the hip and lower back, I see a lot more chronic cases just by the influx of patients and where they come from. So that's probably the most common that I'll see. And then the nerve symptoms. And those are the ones that are tough because when you get a Ming syndrome or you get maybe it is a sciatic issue that's starting at the hip instead of the back. Those are often tough, not to treat, but to educate our patients because they've had someone who's smarter and more educated than I am as far as, people they've seen in the past tell them this is coming from their hip. And then I have to tell them it's not coming from that. And of course, you're going to go to a chiropractor and they're going to say it's coming from the spine. So I always have to navigate that water. But
Right.
no, this is actually coming from the thoracolumbar junction. See, when I push here and it reproduces your hip pain, that's not a hip problem. That's that's a thoracolumbar junction syndrome. So those are probably most common. But I think it has to do with patient education. I think that the more your patients and the more my patients understand their condition, the more that we can educate them on what's causing it and what we're going to do about it, the more compliant they are. And we don't have to suffer from a lot of people have problems with adherence, meaning the patient didn't come back or they saw them 3 times and didn't come back. And I take full ownership of that because it's my job to educate my patient on what happened and what I'm going to do about it. And sometimes it's not seeing me. Maybe sometimes it's just doing rehab or go see someone else. But as long as I educate someone properly, then I shouldn't be ever wondering where that patient went. I should know exactly when they're coming back. I should know exactly where they are in their pathway, and hopefully in their best interest to get them out of pain.
I guess I have one follow-up on that because I think it's interesting because of the setting that you work in. You were mentioning like if they've already seen their like an ortho or a neurologist or something like that, they've gone to a specialist and they had a treatment and it didn't go to plan. Like they're still in pain. How do you navigate that conversation when you might have to say something that's maybe contradictory to what someone else said? Because you obviously don't want to step on other clinicians' toes and say like, well, they were completely wrong. That's not right. I'm right. It's a referral from the spine or, it's this diagnosis. How do you kind of navigate that to kind of maintain relationships with all the parties involved.
Yeah, whenever I have a conversation with anybody, I assume that there's a court listening, and my mom is listening. Sorry, my mom is listening, and that other provider is in the room. And I do that not out of respect for them, but I do it out of respect for myself. That I never want to talk bad about somebody. I never want to say that someone was wrong, because in reality, I might be wrong. So whenever I have that kind of conversation, I say, from our evaluation, here's what I think is going on. Now, unfortunately, the people you've seen so far have not gotten you out of pain, and that's not a problem with them. It's that something happened, or maybe there was some kind of miscommunication, but for whatever reason, the system has not gotten you out of pain. So I have an idea on how to help you. We're going to forget about everything that you've learned so far. It has nothing to do with whether those people are right or wrong, or those are the right exercise or wrong exercise. I have no idea what they were doing. Here's what I think we should be doing. And you may see a little bit of overlap with what the PT was doing, what the other chiropractor was doing. However, we're going to develop a recipe that I think will be successful for you. Now, in order for this to work, you need to comply with everything that I'm going to talk about, because 25% of this care plan is me. The other 75% is you and how well you can follow directions. And if you can't follow my directions, then that's fine. However, I'm not going to be the right provider for you. And I found that the more restrictive I am on who I see, the better off my patients respond to my recommendations, and also my results. That my results are only going to be as good as the patients that I see. And if I walk around Target and someone is there that I didn't get out of pain, I'm going to be the first one to admit it. However, if I didn't get somebody out of pain and I think that, well, it's their fault, well, then that's going to be a problem. That reputation is going to get out there. So, I think just selecting the right people, putting the right people on your bus, and making sure that they understand and what you're trying to do, and you're transparent in all your business policies and all your why you're doing, like, why am I doing isometrics? Why am I doing concentric eccentric? Why am I loading somebody up? As long as you explain that properly, then hopefully you guys can have a relationship and solve their problem.
That's really, really well worded. It was
I have it all written
actually,
down.
oh man, I knew it. You read directly from the blog post. I knew it.
Yeah.
But you'd asked about like a clinical pearl for these conditions, and I really only had one, and I think it piggybacks off of what you just said. Is that a lot of it comes to patient education, and the pearl that I have is when we look at a lot of these conditions, they respond well to heavier load. When we look at like distal hamstring issues, Nordics have been shown to be really effective, and those are heavy eccentric loads. When we look at adductor pain, the Copenhagen exercises, which are more heavy
Have you done those before?
I have. I use a chair to do them, and my groin is so sore after I do it every single time. But there seems to be a trend for a lot of these things that if we load heavy, they respond well. Yes. And I think from a rehab perspective, we have a tendency to underload people quite a bit because we're scared of either flaring things up or causing more damage or something like that. And I think one of the important things for the clinical pearl is that don't be afraid to load. Like, as long as you explain to the patient, we're going to load heavy. There's research to support this. Like, we're not just doing it to be like the macho person to be like, how heavy can you, lift something? We're doing it because this is kind of where the evidence is leading us in terms of like effective treatments. And so, you might be sore afterwards. You might have a little bit of pain while doing it, but that doesn't affect the long-term, or that won't set you back in the long term. It's actually meant to help speed up the recovery process. So really kind of communicating that with the patient so that way, the first time they do something and they're a little bit sore afterwards, or maybe they had a little bit of a flare up, that they're not like, oh great, like it's worse now that I did those exercises. Like I knew that was the wrong person. As long as you're upfront and communicating well with them, they'll, understand that they're doing it for a reason. Also helps with getting them to do it.
Yes. Yeah, I definitely agree. So I tell you what, we're going to go ahead and wind this one down. I've written down a ton of stuff, but I think that what you just said was probably the best piece is to load them heavy and load them safely, to make sure that
Yes.
you're able to do those exercises. And for those kind of those diagnoses that you're treating, those are that'd be the best piece of information to give them through your patient education. So I think one thing we can all agree upon, is that an orthopedics diplomate is better than a rehab diplomate. So we'll go ahead and end it on that.
Cut.
No, I get this question all the time, but I'm gonna let you pitch here, and I want to know why, as a student, as a first year, a fifth year, a 20-year-old doc, why should he be a part of the rehab diplomate?
Yep. I'm gonna pivot that question a little bit and just say, you know what? Like, education is education,
Mm-hmm.
right? And so if it's learning orthopedics really, really well, you understand all, how to test things, what that means for treatment, how you're gonna, work with maybe like post-surgical cases, it doesn't matter as much. Like, you're trying to gain information to help your patients. And so whether that's a sports diplomate, a rehab diplomate, an orthopedics, pediatrics, whatever it is, you're learning things that are interesting to you that are going to help your patients. And so I don't think it really matters which diplomate program you go into. Go rehab, obviously. But it's just about education and providing the most effective treatment that you can for your patients, regardless of where that information actually comes from, or I guess what program it comes from. Not some random internet article that isn't supported by anything.
Exactly. Well, thank you for being a politician about that. And you guys heard it first. We're going to have Braccio Steele for president. And I think that we both will take a hard line on one thing: as long as you are getting yourself better as far as educationally, the less times you're going to say you have hip pain, the less times you're going to say, oh, you sprained something. And the more often you're going to say, here's exactly what's wrong. You have a proximal hamstring injury. Here's exactly what we're going to do to fix that. And here's the prognosis. And the more we can do that with the more patients, the better we're perceived as a profession. And hopefully your business will grow. So thanks for joining us. And hopefully I can grab Dr. Braccio for another meeting and we can talk about something else.
Sounds like a plan. Thanks for having me as always.
All right. Thank you.